Endoscopic Management of Barrett's Esophagus, European Society of Gastrointestinal Endoscopy, ESGE, Position Statement. Introduction. Current practices for the management of Barrett's esophagus, BE, vary across Europe as several national European guidelines exist. This position statement from the European Society of Gastrointestinal Endoscopy, ESGE, is an attempt to homogenize recommendations and, hence, patient management according to the best scientific evidence and other considerations, e.g., health policy. A working group developed consensus statements using the existing national guidelines as a starting point and considering new evidence in the literature. The position statement wishes to contribute to a more cost-effective approach to the care of patients with BE by reducing the number of surveillance endoscopies for patients with a low risk of malignant progression and centralizing care in expert centers for those with high progression rates. In developing this statement, Weusten et al. Focused on issues that were directly relevant to endoscopy practice. Hence, other issues such as chemoprevention for progression of BE or the use of biomarkers for prediction of progression in BE are not part of this position statement. Statement 1. The diagnosis of BE is made if the distal esophagus is lined with columnar epithelium with a minimum length of 1 centimeter, tongues or circular, containing specialized intestinal metaplasia at histopathological examination. Statement 2. Endoscopic screening for BE is not recommended. However, screening can be considered in patients with long-standing GERD symptoms, i.e., greater than 5 years, and multiple risk factors. Age, greater than or equal to 50 years, white race, male sex, obesity, first-degree relative with BE or EAC. Statement 3. Endoscopic surveillance of BE is recommended. Statement 4. High-definition endoscopy, endoscope, processor, and screen, is recommended for endoscopic surveillance of BE. Routine use of chromoendoscopy, optical chromoendoscopy, autofluorescence endoscopy, or confocal laser endomicroscopy is not advised. Statement 5. Endoscopy reports of patients with BE should include 1. The extent of BE using the Prague criteria, circumferential extent, C, maximum extent, M, and any separate islands proximal to the maximal extent. 2. A description of location, in centimeters from the incisors and clockwise orientation, of any visible abnormality within the Barrett's epithelium, in addition to lesion size, millimeters, and macroscopic appearance using the Paris classification. 3. The presence or absence of erosive esophagitis using the Los Angeles classification. 4. The location of biopsies taken from the Barrett segment, number of biopsies, and location in centimeters from the incisors. 5. Appropriate photo documentation of the landmarks and of all visible Barrett's epithelium, as well as any visible lesions. Statement 6. Biopsy samples should be taken from all visible mucosal abnormalities. In addition, random 4-quadrant biopsies should be collected every 2 centimeters within the Barrett segment, starting from the upper end of the gastric folds. Biopsies from each level should be collected in and presented to the pathologist in a separate container. Statement 7. Surveillance intervals for non-dysplastic BE should be stratified according to the length of the Barrett segment. 1. Irregular Z-line or columnar-lined esophagus less than 1 centimeter, no endoscopic surveillance. 2. Maximum extent of BE greater than or equal to 1 centimeter and less than 3 centimeters, 5 years. 3. Maximum extent of BE greater than or equal to 3 centimeters and less than 10 centimeters, 3 years. Patients with BE with a maximum extent greater than or equal to 10 centimeters should be referred for surveillance endoscopies to a BE expert center. If a patient has reached 75 years of age at the time of his or her last surveillance endoscopy and has no previous evidence of dysplasia, no subsequent surveillance endoscopy should be performed. Statement 8. Prophylactic endoscopic therapy, such as ablation therapy, for non-neoplastic BE should not be performed. Statement 9. The diagnosis of any degree of dysplasia, including indefinite for dysplasia, in BE requires confirmation by an expert GI pathologist. Statement 10. Patients with a diagnosis of indefinite for dysplasia, confirmed by a second expert GI pathologist, should be managed with optimization of anti-reflux medication and repeat endoscopy at 6 months. If no definite dysplasia is found in subsequent biopsy samples, including if the biopsies are again classified as indefinite for dysplasia, then the surveillance strategy should follow the recommendation for non-dysplastic BE. Statement 11. Patients with visible lesions in BE diagnosed as dysplasia or early cancer should be referred to a BE expert center. All visible abnormalities, regardless of the degree of dysplasia, should be removed by means of endoscopic resection techniques in order to obtain optimal histopathological staging. Statement 12. Patients with LGD on random biopsies confirmed by a second expert GI pathologist should be referred to a BE expert center. A surveillance interval of 6 months after confirmed LGD diagnosis is recommended. 1. If no dysplasia is found at the 6-month endoscopy, the interval can be broadened to 1 year. After 2 subsequent endoscopies negative for dysplasia, standard surveillance for patients with non-dysplastic BE can be initiated. 2. If a confirmed diagnosis of LGD is found in the subsequent endoscopies, endoscopic ablation should be offered. Statement 13. Patients with HGD confirmed by a second expert GI pathologist should be referred to a BE expert center. In the expert center, a high-definition endoscopy should be repeated according to the following guidelines. 1. All visible abnormalities should be removed by endoscopic resection techniques for adequate histopathological staging. 2. If no lesions suspicious for dysplasia are seen, random 4-quadrant biopsies should be taken. If these biopsies are negative for dysplasia, endoscopy should be repeated at 3 months. If these biopsies confirm the presence of HGD, endoscopic ablation is recommended, preferably with RFA. Statement 14. Endoscopic resection is the first-choice therapy for T1A EAC. Statement 15. In patients with T1B EAC, the optimal treatment strategy depends on histopathological characteristics of the endoscopic resection specimen. Endoscopic resection may be a valid alternative to surgery and is recommended in patients who are borderline fit for surgery if the endoscopic resection specimen meets all of the following criteria. 1. Submucosal invasion limited to less than 5 micrometers. 2. Tumor differentiation grade well or moderate. 3. Absence of tumor invasion in lymphatic vessels or blood vessels. 4. Absence of tumor infiltration in the deep resection margin. Statement 16. After endoscopic resection of visible abnormalities containing any degree of dysplasia or neoplasia, complete eradication of all remaining Barrett's epithelium should be strived for, preferably with RFA. Statement 17. All patients with a BE greater than 10 centimeters, a confirmed diagnosis of LGD, HGD, or early cancer, should be referred to a BE expert center for surveillance and/or treatment. A BE expert center should meet the following requirements. 1. Annual caseload of greater than or equal 10 new patients with endoscopic treatment for HGD or early carcinoma per BE expert endoscopist. 2. Endoscopic and histological care is provided by endoscopists and pathologists who have followed additional training in this field, either by courses or guest visits. A minimum of 30 supervised cases of endoscopic resection and 30 cases of endoscopic ablation should be performed to acquire competence in technical skills, management pathways, and complications. 3. Patients with Barrett's neoplasia are discussed in multidisciplinary meetings with gastroenterologists, surgeons, oncologists, and pathologists. 4. Access to experienced esophageal surgery. 5. All patients with BE are registered prospectively in a database.